When I tell patients they need chemotherapy or radiation, they always ask, which one? Here is what most don't realize. We breast cancer doctors use specific decision tree, and I'm going to tell you exactly how we make that call. Chemotherapy and radiation therapy do different jobs in different places in the body. Chemotherapy is a medication that goes into your bloodstream. It's given intravenously and goes all around your body. Its job is to hunt for tiny cancer cells that escaped your breast, even if the scan can't see them yet. Think of a cancer like a mint plant growing in your garden. If you've ever grown a mint, it just doesn't stay in one place. It sends these runners under the ground, popping up in unexpected places all over your garden. When we do surgery, we cut this mint plant down at the ground level. But the problem is those runners that go underground might still be there, ready to grow back. Just give it a little bit of water. And this is where the chemotherapy comes in. Think of it as a special weed killer that travels all around your body. We inject it at that base of that mint plant, and it flows everywhere through your system, hunting down every single mint shoot, no matter where it's hiding. While radiation is a very focused treatment aimed at the specific area, either the breast or the chest wall or the lymph nodes. Radiation is like applying a fake tan. It only works where you put it. Its job is to treat cancer cells that might be left in the exact spot after surgery, reducing the chance of cancer coming back there. And it's just, as I said, like a fake tan, only darkens the skin where you applied it. And the radiation only affects the area that we are targeting, like the breast, like the armpit lymph nodes, like the collarbone lymph nodes. How do we actually make the chemotherapy decisions? And what are the factors of the breast cancer that tells us, doctors, should we use chemotherapy or not? First one is the grade. And we talked about it before. Tumor grade is like a speed rating or a personality of the cancer. Grade 1 are slow growing and well behaved. Grade 3 tumors are fast growing and more aggressive tumors. If you have a grade 3 tumor, we're very likely to recommend chemotherapy. Why? Because these cells are growing quickly and are more likely to spread somewhere else. So we want that systemic weed killer traveling through your body to catch any cells that might have escaped. I've recently had 64-year-old lady with a grade 3 tumor that oncologists have decided to offer chemotherapy after her breast cancer surgery, even though her lymph nodes were negative. On the other hand, if you have a grade 1 tumor, chemotherapy is much less likely. These are slow-growing tumors that are less aggressive, and often surgery plus radiation and hormone treatment is enough to keep you safe. And the grade 2 tumors fall somewhere in between. That's where we look at other factors like lymph nodes, status, and your individual situation to make these decisions. Now, the tumor grade doesn't work alone. We also need to look at your lymph nodes. If you have a grade 2 or 3 tumor and cancer has reached your lymph nodes, you're very likely that we will recommend chemotherapy. This combination shows you that the cancer is more aggressive and it's already spread into the lymph node. So we want that systemic weed killer working throughout your body to kill any cells that have escaped. But if you have a grade 1 tumor with 3 lymph nodes positive, that's ER/PR positive, we're probably not going to recommend for you to have chemotherapy. And this is the story of another of my recent patients who has had 2 centimeter right side breast tumor with 2 lymph nodes involved, who was in her 70s, that was ER positive and PR positive and HER2 negative cancer. So the oncologist did not recommend for this lady to have chemotherapy, because the chemotherapy in this situation more likely to be associated with more side effects and not as good benefits for this lady. So the risk would outweigh the benefits. The third factor that we'll look into is the hormone receptors like ER, PR, and a HER2 status. And in the previous video, I have talked more in depth about the HER2 tumors. And think of the HER2 positive cancer as being growth accelerators. It tells cells to grow fast and divide fast. So if the tumor is 5 millimeters or bigger, that's a tiny, it's like a pencil eraser, we're very likely to recommend women with this type of cancer to have chemotherapy. And this is because we have a specific chemotherapy that we add to a normal chemotherapy that basically puts a brake on this accelerator so you cannot actually drive this car any faster. The other hormone receptors we look at is estrogen and progesterone, especially if the cancers have lost that receptor. Some breast cancer cells respond by our hormones like estrogen, and they're called estrogen positive, while there are others who don't respond and they're estrogen negatives. So if you have estrogen negative breast cancer, we often end up recommending chemotherapy in this situation. And the reason for it is that we don't have tablets that will block this receptor like tamoxifen or aromatase inhibitor. So chemotherapy becomes our main systemic treatment to hunt down these cancer cells. Now, the other factor is age, and with that, it's associated overall person's health. So the younger women are more likely to be offered chemotherapy than older women, even with the same tumors. And the reason for it is that we assume that younger women have longer lifespan than older women. So we assume that a woman who's in her 30s and develops breast cancer is going to hopefully live to her 70s or 80s, but the woman who is in her 70s will only also live to 80, and that's only 10 years versus, let's say, 40 to 50 years. The younger a person is, we assume that their body will tolerate chemotherapy better with less side effects, so they will get more benefit from that chemotherapy. If a woman is in her 70s or 80s, it doesn't mean we won't give them chemotherapy. We have to weigh these things much more carefully because the potential benefit might be smaller, but also the body might not deal with the chemotherapy as well, so they might have higher risk of side effects. And your general health fitness also matters because chemotherapy is quite tough on your body. It affects your immune system, your energy level, how you feel day to day. So if you have serious heart disease, really bad diabetes related complications or kidney issues, the chemotherapy might not be in your best interest. Because, as said, treatment could cause more harm than potentially cancer coming. This is what catches most people off guard about chemotherapy timing. In some situations, you can have chemotherapy before having the surgery. And these are, 1, if you have HER2 positive breast cancer with or without lymph nodes being involved. 2, if you have a grade 3 ER positive, PR positive breast cancer with lymph node metastases. 3, if you have a ER negative breast cancer with lymph node metastases. In these situations, it is very likely that you're going to have chemotherapy before you have your surgery. How do we make radiation decisions? If you've had lumpectomy or breast conserving surgery, we've just removed tumor and a little bit of normal, healthy breast tissue around it. We always recommend that you have radiation. Why? Because we've left most of your breast tissue behind. So we want to be sure that any microscopic cancer that might be hiding in the remaining tissue can't grow back. Now, if you've had mastectomy, where we've removed all breast tissue, you might think radiation is not needed. And often you're right. But there are some situations where we still recommend radiation. And that is if your tumor was quite big, so 5 centimeters or bigger, if the tumor was growing into the skin or into your muscles or chest wall, if the cancer was found in lymph nodes, or if the margins weren't as clear as we'd like them to be. In these cases, even though the breast is gone, we may radiate the chest wall and surrounding areas to catch any cells that might be lingering there. When do we normally give you radiation? So radiation doesn't happen straight away. There is careful sequence that we follow when it comes to radiation. So if you've had surgery and you need chemotherapy, then chemotherapy will come first and the radiation comes afterwards. And we need to let your body recover for 3 to 4 weeks before we can give you the radiation after chemotherapy. Now, if you've had surgery only, but you don't need the radiation, then we'll let your body recover 5 to 6 weeks, and then you end up having radiation. And this is to minimize the risk of radiation with the healing process from your surgery or chemotherapy. Why chemotherapy and radiation for some women? Here is what most women don't realize. Remember that analogy. Chemotherapy is like a weed killer spreading through your entire garden, hunting down any cancer cells wherever they might be hiding in your body. And radiation is like a fake tan. It only works where it's applied, chest wall, armpit lymph nodes, collarbone, or the breastbone lymph nodes, and treating the specific area that a cancer was in. They're doing completely different jobs, which is why in some situations we give them together. Like I said earlier, chemotherapy always comes first. The reason is because it's working throughout your whole body. We want to get that systemic protection as soon as possible after surgery. Exception for this rule of chemo first and then radiation. Occasionally, chemotherapy can be given at the same time as radiation. And that is, you've had your main chemotherapy first, and then you continue with your Herceptin chemotherapy, the HER2 positive cancer targeted chemotherapy. During the HER2 only part of chemotherapy, we can give you radiation at the same time. Does this plan actually work? Your treatment plan, it's about doing exactly what your cancer specific needs are to give you the best outcome. So radiation after lumpectomy reduces recurrence rate in the breast by 50%. If we give you radiation to the lymph nodes, because you've had lymph nodes positive, we know that increases your overall survival by 2 to 3%. And this is absolute survival, not relative survival. Chemotherapy reduces your breast cancer mortality by around 30 to 40%. And that's the relative risk reduction. Important questions to ask your breast cancer doctors. What is my tumor receptor status? ER, PR, HER2, and Ki67. What is my tumor grade and stage? Why are you recommending this sequence of treatment and not this one? What are the side effects of my treatment? Treatment for your breast cancer is never one size fits all decision. It's about finding the right treatment for you at your age, with your health and your specific cancer. If you're facing this decision, drop a comment below with your question and I'll read and pretty much answer all of them. If this has helped clarify the process, subscribe, because in the next video, I'm breaking down how we breast cancer doctors decide which endocrine tablet patients should take, tamoxifen or aromatase inhibitor.